All right, number one, movements and physical activity application, movements of the hip and the pelvic girdle. First, we've got flexion, up, extension, back, abduction, adduction, external rotation, internal rotation, diagonal abduction, diagonal adduction, anterior pelvic rotation, posterior pelvic rotation, and then we've got left transverse pelvic rotation where the left side of the hip moves anteriorly towards the as opposed to the right, and then right transverse pelvic rotation where the right hip comes forward. All right, so for the first question in the movements and physical activity application, listing a sport that you see diagonal adduction. Soccer and football, especially the kicker in football, come to mind. I think the best example is the kicker in football. You really see that exaggerated diagonal adduction when he kicks the ball, say a field goal or even a kickoff. Um, that's the most obvious one. The second question, how does anterior and posterior pelvic tilt apply to weightlifting? It really comes down to overlifting certain areas and underlifting other areas and improper stretching. Anterior tilt is indicative of an overly tight abdominal area as well as overworked muscles like the tensor fasciae latae, rectus femoris, or other muscles that are in front of the pelvis that work on hip flexion. Uh, in addition to those being overworked or too strong or too tight, they could have a weak uh, backside, rather. So muscles on the backside, the glutes, back muscles that are very weak or loose. The combination of the two, you'll see an increased lordotic curve where it's the muscles in the front are pulling forward on the pelvis, which gives it that really extreme curve. And of course, the more curve you see, the more back pain, and you're seeing damage to discs, to ligaments, to tendons, you name it, and that's just due to improper lifting and stretching. And you can also have anterior pelvic tilt with sitting too much, and so you see anterior tilt, excuse me, way more often than you do posterior. You can have anterior tilt simply from standing too much. If you lock your knees, the muscles have to kind of adjust to the stance you're in, and it just naturally pulls the pelvis forward so that you can stand correctly. But posterior tilt you see mostly in weightlifters, and that's because you'll see weightlifters focus way too much on certain areas like the hamstrings, the glutes, lower abdominal muscles, um, and then they don't work out as much on their quads, psoas muscles, or lower back muscles, and so that um, imbalance will create the posterior pelvic tilt, and that lordotic curve will pretty much disappear. It'll be really flat, as I demonstrated in the previous clip. All right, number two, the muscle analysis chart for the hip and joint. We've got abduction and adduction. For abduction, the movement is where the femur moves laterally through the frontal plane away from the midline. And right here you've got the gluteus medius and minimus and the upper fibers of the gluteus maximus. You've got the sartorius, which originates on the anterior superior iliac spine and then inserts onto the anterior medial surface of the tibia below the condyle. You've got tensor fasciae latae, which originates on the anterior iliac crest and then inserts onto Gerdy's tubercle on the knee. Okay, so for adduction, you've got the leg going in where the femur is moving medially through the frontal plane towards the midline. Muscles that are used there are the pectineus, that originates on the front of the pubis and then inserts onto an area between the lesser trochanter and the linea aspera. And then another one is the adductor brevis, which originates from the inferior pubic ramus and inserts onto the lower two-thirds of the pectineal line and part of the medial lip of the linea aspera. Other muscles that are used for adduction are the adductor longus, adductor magnus, gracilis, and the gluteus maximus. All right, number 3, the hip joint exercise movement analysis with the hip sled machine. To go ahead and look at the movement phase, the joint movements, and the agonist muscles. The first phase in the exercise is the lowering phase. The agonist muscles for the lowering phase for hip flexion is the iliopsoas, the rectus femoris, the sartorius, pectineus, adductor brevis, adductor longus, the gracilis, both the gluteus medius and minimus, and the tensor fasciae latae. With knee flexion, you've got the rectus femoris, sartorius, the gracilis, semitendinosus, and membranosus, and the biceps femoris. Those are for flexion, and that is, you do see flexion with the lowering phase, but I feel like for this exercise, with the position that she's in with the weight coming down, it's not as much of a concentric hip or knee flexion exercise. It's more of a eccentric hip and knee extension exercise, and you can see it in the lowering phase where I feel like the hip flexors and the knee flexors are more used as stabilizers so that you don't injure yourself. So you are working out those muscles, but it's not a concentric exercise for those muscles. It's not really targeting those muscles. Um, on the second phase, on the pushing phase, which is where the most explosion comes from in the exercise, the concentric contractions. For hip extension, you're using the gluteus maximus, the adductor magnus, semitendinosus, semimembranosus, biceps femoris, and the gluteus medius. And then for knee extension, you've got rectus femoris. I feel like this exercise will strengthen hip flexors and knee flexion, but only to a certain degree, because they're not the ones that are targeted in the exercise. Um, Again, I would say that they're more for stabilization. Um, it's a very explosive exercise that focuses on the extensors, um, and I think that eccentric contraction on the lowering phase is just going to build up more endurance for those extensors during the lowering phase.